Okay. So good afternoon. And the session was the ASLD and APASL research methodological workshop. So the first presenter is not coming yet on the web. So and the second presenter, Dr. Chang Han. So please start your lecture.
Good afternoon, professors, ladies and gentlemen. I'm Shangjun Huang from National Taiwan University Hospital. Today, my topic is the impact of metabolic dysfunctions on mortality in chronic hepatitis B patients with concurrent steatotic liver disease. This is my disclosure. Steatotic liver disease, which means fatty liver, is prevalent within the chronic hepatitis B population up to around 1/3. The old criteria was NAFLD, and in 2022, the criteria of MAFLD was proposed, and last year, the newest one, MASLD, was proposed. The diagnosis of MASLD was composed of two components, hepatic steatosis and systemic metabolic dysfunctions, A, B, C, D, E. Either one, then the diagnosis of MASLD can be made. In our earlier studies, metabolic dysfunction was proven for increased risk of adverse liver outcomes in chronic hepatitis B patients, including in one of our studies, we found metabolic dysfunction will increase the risk of HCC in a dose-dependent manner. The higher burden of metabolic dysfunction, the higher risk of HCC. In another study, cirrhosis, we also found similar finding. The higher metabolic burden, the higher risk of cirrhosis. However, its impact on long-term survival remains unknown. As a result, this study aims to investigate the impact of metabolic dysfunctions on all-cause and cause-specific mortality among chronic hepatitis B patients with concurrent steatotic liver disease. This is the flow chart of patient selection. First, we enroll chronic hepatitis B patients with steatotic liver disease at our hospital. And then, after the exclusion, we use the criteria of MASLD to examine whether they had metabolic dysfunction or not. Furthermore, we also calculate the metabolic burden, which was defined by the fulfilled number of metabolic dysfunctions. For example, if a patient had a DM and hypertension, then he got 2 points for metabolic burden. And then we classify patients into MASLD and non-MASLD groups for comparison. The study endpoints are all-cause mortality and cause-specific mortality. We further link our patient to the nationwide level data, the National Death Certification System in Taiwan, to confirm their survival status, the cause of mortality, and the date of death. Finally, we identify 8,780 chronic hepatitis B patients with concurrent steatotic liver disease. The median follow-up time was 9 years. The majority of these patients had concurrent MASLD. At baseline, patients with MASLD had older age and higher proportion of male sex. Interestingly, at baseline, patients with concurrent MASLD had a lower proportion of E antigen positivity and a lower median HBV DNA, indicating that MASLD is associated with a lower HBV viral activity. After follow-up, those with concurrent MASLD had a higher risk of mortality. The adjusted hazard ratio was at 1.79 after adjustment for clinical and viral factors. Furthermore, if we focus on the cause of mortality, we can find the green one, the liver-related mortality proportion was much higher than those without MASLD. So MASLD also increased liver-related mortality. Furthermore, metabolic dysfunction had a dose-dependent effect. The higher metabolic burden, the higher risk of all-cause mortality. In a multivariable adjustment, patients with MASLD and 3 and more metabolic dysfunctions had the highest risk, and patients without MASLD had the lowest risk after adjustment. The dose-dependent effect was also seen on the cause-specific mortality, including the liver-related mortality. The green line means those with 3 or more metabolic dysfunction had the highest risk of mortality. Similarly, non-liver cancer-related mortality showed a similar trend. Also, cardiovascular mortality was found the similar findings. As a result, dose-dependent effect was found among our patients. It's the current summary. Concurrent muscle increase all-cause and various cause-specific mortality, and metabolic dysfunctions has a dose-dependent effect. How about new onset metabolic dysfunction during the follow-up period? Because the prevalence of metabolic syndrome is increasing, some patients do not have metabolic dysfunction at baseline, but develop metabolic dysfunction during our follow-up period. As for the DM, we can see here, the pre-existing DM had the highest risk. However, those developed new onset DM also increase the risk of all-cause mortality. Similarly, hypertension, the new onset hypertension also increase the risk of mortality. Furthermore, if a patient develops new onset DM and new onset hypertension, then the all-cause mortality and the cause and liver-related mortality will increase up to more than 3 times. So pre-existing and new onset metabolic dysfunction increase the risk among our patients. We also perform some sensitivity analysis to confirm our results, including IPTW to balance the baseline characteristics and multiple imputation for missing data. All the results confirm that metabolic dysfunction increase the risk. So it's a summary of my analysis. Metabolic dysfunction increase the risk of all-cause and cause-specific mortality in a dose-dependent manner. And new onset DM and hypertension also increase the risk. And metabolic dysfunction is associated with a lower viral activity. Now it's a discussion. According to our results, aggressively identifying and managing these metabolic dysfunctions are important in clinical practice because new onset metabolic dysfunction also increase the risk. As a result, periodic screening for metabolic syndrome is needed for chronic hepatitis B patients with concurrent steatotic liver disease. Furthermore, we also found that the inverse COVID relation between MASLD and HBV viral activity. This finding is consistent with our earlier studies and other animal and cellular studies. For example, in one of our studies, we found concurrent MASLD facilitated hepatitis B surface antigen loss, the functional cure, and the higher burden of metabolic dysfunction, the higher probability of surface antigen loss, which means there are also a dose-dependent effect on the viral suppression of MASLD. So I will use this figure from our recent paper in CLD to summarize this finding. At the right side, metabolic dysfunctions will increase the risk of cirrhosis, HCC, liver-related mortality, and finally, all-cause mortality among chronic hepatitis B patients. However, on the other hand, hepatic steatosis may suppress HBV viral activity, facilitate surface antigen loss, finally, may reduce the risk of adverse liver outcomes. So, in our earlier study, we also observed hepatic steatosis without metabolic dysfunction, which means pure hepatic steatosis is protective against the HCC and cirrhosis. As a result, the impact of metabolic disorders on chronic hepatitis B patients is diverse and even paradoxical. And we need more studies to confirm the detailed mechanisms and the impact of these factors on chronic hepatitis B patients. Ladies and gentlemen, here comes the conclusion. Pre-existing and new onset metabolic dysfunctions independently increase the risk of all-cause mortality, liver-related mortality, and cardiovascular mortality among chronic hepatitis B patients with concurrent steatotic liver disease. As a result, periodic monitoring is recommended for this patient for the metabolic comorbidities to potentially improve long-term outcome. More mechanistic studies are needed to confirm the interaction between MASLD and HBV, and these findings may contribute to the potential therapeutic targets against HBV infection. Thank you very much. Thanks for my mentor, Professor Gao, and my colleagues in National Taiwan University Hospital for their support. And if you have any chance to come to Taiwan, don't hesitate to tell me. I can be the tour guide for you. Thank you very much. This is my presentation.
Thank you for nice presentation. So this paper is now open to question and comments.
So,
Okay.
Dr. Huang, my name is Junji Zabo. I'm from Harvard University. Very nice presentation. Thank you. So I have a few questions. One is that can you kind of tell me what was the rationale for choosing the chronic hepatitis B infected patients? And if I understand correctly, you chose patients to start with who had also steatotic liver disease. Why not taking any chronic hepatitis B patients?
Yes, thank you, Professor. This is a very, very important question because those with concurrent steatotic liver disease are presumed to have a higher risk of metabolic comorbidities. So we start with this high-risk population for our analysis. However, we also have other patients without steatotic liver disease in our cohort. And in our preliminary analysis, among this patient, metabolic dysfunction also increases the risk. However, the presence of hepatic steatosis will alter the impact of metabolic dysfunction as described. The pure hepatic steatosis may be protective against liver-related mortality in chronic hepatitis B patients, probably due to viral suppression. And this needs more comprehensive study to investigate the detailed mechanisms and other correlation with other potential confounding factor or something else. So in this study, because of the size and of the study, we need to focus only one factor at only one study. Because if we include those without steatotic liver disease, the analysis and the topic of our paper will be maybe different. But it's difficult to put them in only one study because they are different topics. So we first include those with steatotic liver disease because they are presumed to have higher prevalence of metabolic syndrome. So it's also prevalent in our clinical studies. Yes, thank you.
So any other questions or comments? So please.
Shang-Xin, a very nice paper. Congratulations. So what are your thoughts on the use of aspirin or statin in your patients, like Hep B plus steatotic liver disease? Do you think there would be any benefit, especially considering you showed us a lot of data on the CV death and the other cause of mortality, etc.? Any thoughts?
Excuse me. So you are asking about what's the implication of our result, or sorry?
Or do you have any data on aspirin statin?
Okay, so you means how can I apply this result to my clinical practice, right?
Yeah, sure.
Yes.
Yeah,
okay. Yeah. So because in Taiwan, those with chronic hepatitis B are not routinely screened for metabolic dysfunctions or metabolic syndrome. Not everybody receives blood tests for sugar or dyslipidemia annually. However, according to our result, those with concurrent steatotic liver disease had higher prevalence of metabolic syndrome. And the metabolic syndrome or metabolic dysfunctions will increase the risk of liver-related mortality, including HCC, cirrhosis, or others. So this chronic hepatitis B patient, during their follow-up, they may need to also screen for their metabolic syndrome as a routine or recommendation. Because these factors are useful for risk stratification, or potentially we can manage these factors to improve the long-term outcome. As a result, I think the major finding of our study is that we should pay more attention to metabolic dysfunctions among these chronic hepatitis B patients, because it's not the routine care in our clinical practice. We only maybe test for ALT, AST, and alpha-fetoprotein every 3 or 6 months and ultrasonography. But not everybody receives HbA1c dyslipidemia survey. Yes.
Thank you. Thank you.
Thank you.
So I have one question.
thank
So is there any difference, the frequency of the steatosis, steatotic livers, between the chronic hepatitis B patient and non-chronic hepatitis patient?
Yeah, thank you for Professor, your important question. Because we in this cohort we enroll only those with chronic hepatitis B patient. However, according to previous studies, there are inverse correlation, which means the general population had a higher prevalence of steatotic liver disease than those with chronic hepatitis B infection. So those with chronic hepatitis B infection had a lower prevalence of SLD, according to previous studies and meta-analysis. However, the detailed mechanism, what's the mechanism, is not clearly known. So this may be our future study goal.
Yeah, it's very interesting finding. Thank you.
Thank you.
Yeah.
Good afternoon. I am Professor of Gastroenterology, Tirunelveli Medical College, Tirunelveli. And you say that metabolic dysfunctions have a beneficial effect over the chronic hepatitis B progression, it seems. Am I right?
Excuse me. So you are asking about whether metabolic dysfunction a risk factor or favorable risk factor for chronic hepatitis B infection? Yeah, I think it's risk factor. And because I do not have, could you please show my slide? Thank you. And in our study, metabolic syndrome, metabolic factors, including DM, hypertension, they are risk factor for HCC and cirrhosis. However, pure hepatic steatosis is protective against HCC in our earlier study among chronic hepatitis B patients. As can be seen in our last review article figure, we can see at the right side, although hepatic steatosis and metabolic dysfunction are highly correlated, but they have different effects on chronic hepatitis B infection. Metabolic dysfunction will increase the risk of adverse liver outcomes. However, hepatic steatosis may suppress HBV viral activity, facilitate surface antigen loss, and this will lead to lower risk of cirrhosis and HCC based on our and other groups study, and even a new latest meta-analysis also show this effect. So they have diverse effects on chronic hepatitis B infection. As a result, I did not show the supplementary data, but I can summarize use this figure. MASLD is composed of metabolic dysfunction and hepatic steatosis, and right side is the final effects on HCC risk. If a patient has hepatic steatosis, but they have different metabolic burden, for example, higher metabolic burden, then HCC risk will be higher than those without steatotic liver disease. However, if a patient has a simple steatosis or steatosis but minimal metabolic dysfunction, then the HCC risk will decrease. It's because hepatic steatosis is protective, but the metabolic dysfunction accompanying metabolic will change the risk of HCC. If a patient has steatosis disease but also have DM, then DM will increase much the risk, leading to a higher risk of HCC among these patients. So the final impact is variable. It depends on the metabolic burden. So we maybe in future studies, we need to separate metabolic dysfunction and hepatic steatosis for our analysis because they have different effects on chronic hepatitis B patients.
So the follow-up studies, whether it's an initial presentation of steatotic liver disease to the endpoint of cirrhosis, or has it been followed? Just a concept of if we reduce just because there is a low HbA conversion or loss, does it implicate it will progress to an endpoint? That will it reach the endpoint of development of cirrhosis and HCC?
Okay, in current study, in this study, we only include patients with chronic hepatitis B patient with concurrent steatotic liver disease. So all our patients had fatty liver. As a result, in this study, we only examine the effect of metabolic burden and metabolic dysfunction. But in our earlier study, as shown here, if a MAFLD patient had a lower risk of HCC, lower risk because I just said previously, yes. So So, but this study do not answer this question because all our patients in this study have fatty liver.
And all the metabolic dysfunction patients, have they undergone therapy? They have been treated. For example, hyperlipidemia or diabetes. Have they under treatment or not?
Oh, yes. Some people are under treatment, but some people not. So some people receive medication, but some people not. Yes, in our analysis. But we put them together. If a patient had the diagnosis of DM or receiving the medication for DM or have a higher HbA1c, then we define him as type 2 DM as in our analysis.
Maybe the confounding factors, the therapeutic effect of individual patient. Some patient may be diabetes, some patient may be hyperlipidemic, or some patient may be obesity. All these can it influence the development of HB surface loss or a degree 0 conversion. They may be maybe adding on to the effect of the study.
Yeah, so different metabolic dysfunction have different effects on chronic hepatitis B infection. For example, in cirrhosis and HCC, DM is the most potent risk factor. DM is most potent than others. And dyslipidemia may be neutral or near neutral. So different metabolic dysfunction have different effects on chronic hepatitis B infection. Yeah, we show this data in the supplementary data, but not here. Yeah.
Okay, thank you.
Thank you very much.
Thank you so much. I think we just exhausted the time,
Yeah.
and we appreciate your presentation and great answers. Thank you.
Thank you.
So it gives me great pleasure to invite the next speaker, Dr. Tsutsumi, who is coming from Kurami University from Osaka.
No.
No?
Kobe University from. I'm sorry.
Then okay. Doctor. Oh, okay.
Good
You're
evening.
on Zoom.
Yeah.
Good. Okay, so you're coming from Zoom and he's going to talk about hepatic lobular inflammation in the most impacted prognostic factor in MAFLD, a multi-center study.
Hi, good afternoon, everyone. Can you hear me clearly?
Yes, we can hear you. Please go ahead. Perfect.
Thank you. It is a great honor to be able to speak to you today. Before I start, I thank President Dr. Shina and the moderators for giving me an opportunity to talk. Today, I'd like to talk about mortality in patients with MAFLD and their prognosis pathological findings. Here is our disclosure. MAFLD is characterized by its inclusion criteria. Patients with MAFLD are classified into those with who are obese or overweight, those with diabetes, and those with multiple metabolic functions who are lean or normal weight. By defining these clear diagnostic parameters, we pave the way for targeted treatment approaches and better patient outcomes. It is widely recognized that the diagnosis criteria for MAFLD differ from those of the conventional NAFLD criteria. NAFLD is diagnosed by exclusion criteria. When steatosis is present without moderate to heavy alcohol use and other liver disease are ruled out. In contrast, MAFLD's criteria are inclusive according for metabolic dysfunctions and do not exclude cases with moderate alcohol intake or coexisting viral hepatitis. We have previously reported on the utility of diagnostic criteria for MAFLD. Our research team suggests that MAFLD is more suitable than NAFLD for identifying patients with high risk liver fibrosis and cardiovascular risk, etc. In addition, another research shows that MAFLD has a worse prognosis than NAFLD. However, there is little evidence of detailed pathology related to the prognosis of patients with MAFLD. Therefore, our study aims to fill this gap by investigating the detailed pathology associated with MAFLD prognosis. Our retrospective observational study designs aimed to provide insight into the long-term prognosis associated with MAFLD. We enrolled 1,950 participants who underwent liver biopsies from multi-domestic institutions. Finally, we classified the 1,444 patients into these three groups according to the presence or absence of steatosis and metabolic abnormalities. These without steatosis on liver biopsy were defined as burnout steatosis group. Patients who met both criteria for steatosis and metabolic dysfunction were categorized as MAFLD group. In contrast, individuals presenting with steatosis but without the associated metabolic dysfunction were placed into the non-MAFLD group. This slide presents patient characteristics across these three groups. The majority of the study cohort is MAFLD group. There are no significant difference among three groups in age, female ratio, BMI, and alcohol consumption. However, significant difference are noted in the prevalence of diabetes, hypertension, and lipid profiles, which are more common in the MAFLD group. This slide presents, this slide on the left side, we demonstrate the prognosis and cause of mortality in each of the three groups. The burnout steatosis group showed a worst prognosis in the three groups. The MAFLD group showed more worse prognosis than that of non-MAFLD group. On the right side, we demonstrate the cause of death of each group. Among the MAFLD group, the total number of deaths was the highest. In the burnout steatosis group, 2/3 of the cause of death were related to liver-related mortality. And whereas in the MAFLD group, 60% of the cause of death were extrahepatic events. Notably, no patient had died in patients with the non-MAFLD group. This result was pathological findings for the three groups. The statistical analysis shows a significant difference among the three groups. The MAFLD group the MAFLD group is characterized by a high NAFLD activity score. In contrast, the non-MAFLD group showed a different pathology altogether with lower NAFLD activity score and fibrosis stage. Meanwhile, the burnout steatosis group is noted to have a more advanced fibrosis. This slide shows the patient between prognosis and pathological findings in MAFLD and burnout steatosis group. Black color shows patient with died and white is alive. In the MAFLD group, hepatic inflammation is identified as an upstream factor for mortality. Patient with high grade of inflammation, burning, and fibrosis had a mortality rate of 17%. On the other hand, in the burnout steatosis group, fibrosis stands out as a most crucial factor influencing mortality. Of those with fibrosis, the mortality rate was at 50%. These graphics indicate that in both MAFLD and burnout conditions, the group with the most advanced fibrosis has the poorest prognosis. However, for MAFLD group, hepatic inflammation has emerged as an upstream prognostic factor. Its pivotal role in the progression of the disease. As a sub-analysis, we investigate what metabolic factors are associated with the prevalence of high grade of hepatic inflammation in MAFLD group. Diabetes and hypertension are showed and metabolic abnormalities that are associated with higher rates of hepatic inflammation in MAFLD. These results suggest that diabetes and hypertension may contribute to higher rates of severe liver inflammation in MAFLD patients. In conclusion, MAFLD had significantly worse prognosis, pathological findings, and mortality than the non-MAFLD group. Hepatic inflammation was an important pathology for the prognosis of MAFLD. Diabetes and hypertension were associated with hepatic inflammation in patients with MAFLD. I'd like to express my sincere to JSD MAFLD group. Thank you so much.
Thank you for this presentation. Now this is open for questions. I don't know if you're anyone from the audience.
Yes.
Yes.
So thank you, nice presentation. So I'm Hayato Hikita from Osaka University. So if you sub-analyze the mortality, for example, so the liver-related disease or non-liver-related death, so the both the mortality is important in the liver inflammation in MAFLD group.
Thank you. You are very important question. I couldn't show in this presentation. In patient with MAFLD who died caused by liver-related risk, they have the high prevalence of hepatic fibrosis. On the other hand, MAFLD patient who died by extrahepatic events, including extrahepatic cancer, associated with hepatic inflammation.
Thank you. So, how did you guess the why? Why those extrahepatic cancer increase the liver inflammation?
Thank you for your question. So, hepatic inflammation. Some previously reported that hepatic inflammation associated with extrahepatic cancer due to the multi-organ cell apoptosis, and especially in Asian fatty liver patients, they have lower incidence of cardiovascular disease than Eastern patients.
Thank you.
Thank you. So I would have a question that just can you tell me why are you calling this MAFLD when in an essence you're showing that there's a lot of inflammation in these patients? So it wouldn't be like the nomenclature would be that those are MASH patients. I don't know, how do you what was the logic?
Sorry, could you please rephrase your question?
Please say slowly. He asked him more slowly. Please say again your question.
Oh yeah. So a question was that the nomenclature that was introduced just in the last year about the MAFLD and MASH kind of identifies that the MAFLD with inflammation would what we call MASH, right? So I was just confused. Why are you not calling it as MASH in that patient population that had the MAFLD and inflammation? I think it's a technicality.
I see. Thank you for your question. Your question is very important issue. However, I couldn't investigate the prevalence of MASH or at risk MASH findings in this study. So this is my further investigate program. Thank you so much.
Okay. Any other questions from the audience?
So one more question.
Yes.
So you said that information is the most important in the MAFLD groups for the mortality. So when you check the laboratory data, for example, ALT levels or AST levels are important in the predictive factor for the all cause of mortality. Is it right?
Yeah, thank you for your very important question. Couldn't investigate the association mortality between the serum level of AST and ALT and mortality, but I guess it may be associated the liver function and mortality, liver function and hepatic inflammation.
Thank you so much. So scheduling a little change, now delaying, so cross.
Okay. So thank you so much. I think there are no other questions from the audience, so we appreciate your talk and thanks very much again.
Thanks so much. So that presenter is Dr. Erang Divya from India. Please start the lecture. Well, is there okay?
This is the his talk.
He didn't upload it.
See, which country is fit from?
India.
Oh. You can upload it here. You
Yeah.
have to go within the. Okay.
So this is the last presentation.
And then is there another session?
Oh yes, after that.
Are you doing that too?
Oh no. Ask. これってちょっと入れ替えることできるんですか？入れ替える。結構時間かかりますね。うん。じゃあいけますね。No, is it the correct slide?
Probably.
No.
Yeah.
So okay, please start your lecture.
Okay, good afternoon to everyone. So I'm Dr. Divya. So at the outset, I would like to thank the APASL for giving me this opportunity to present here. So I'm Dr. Divya from Tirunelveli Medical College, Tamil Nadu, India. So before going on to the presentation, I would like to ask, so how many of you do have a regular workout? How many of you do a regular exercise on a daily basis? Okay, so among like few people, only one of you have raised your hands. Okay, fine. So let me go on to my topic as such. So my topic is prevalence and risk factors for metabolic associated fatty liver disease in South Indian population. So, okay, so coming on to the background, there's been a change in nomenclature, as we all know, from NAFLD to MAFLD, which was proposed in 2020. So MAFLD focuses on the presence of certain risk factors and associated metabolic comorbidities. And we all know that there's been an increase in fatty liver disease burden all over the world, especially even in India, over the past 3 decades. And it has become steadily increasing and may become the leading cause of chronic liver disease in the coming decades. So it is important to emphasize that this disease is a systemic disease. So this is the atlas showing the prevalence of MAFLD throughout the world. And we can see the Asian countries have quite a high prevalence, especially India and Japan are almost on the same level. So we have a prevalence rate of more than 30%. So as I already said, so prevalence of fatty liver disease has been quite high in India from 20 to 55%. And especially, as you all know, it's going to be increasing with diabetes, obesity, and metabolic syndrome. And the burden is not only high even in the urban areas. Now, even in rural areas, we are getting to see quite a lot of fatty liver disease. And especially now, we are getting a lot of cryptogenic cirrhosis, especially among the females. So it has been projected that around 15 to 20% of patients with NASH, known MASH, so will have liver cirrhosis within 10 to 20 years. So the estimated number of liver diseases is going to be increasing. So it has been projected that it's going to increase like around 178% by 2030. So yes, so when the prevalence of MAFLD increases, the incidence of complications also going to increase. So MASH, decompensated cirrhosis, HCC, and now NAFLD is the most common cause for liver, second most common cause for liver transplant, but it is quite probable that it's going to be soon be the first one. So despite awareness of the progressive increase in the incidence of the disease, there has been no significant progress in the treatment and management in the last few years. And as I said, so I'm from India. So India has a population of around, so more than 70 million. And in India, we have so many states, and I'm from Tamil Nadu, the southernmost state. So Tamil Nadu has a population of around 7 million. And in that, I'm from Tirunelveli. So we have so many, such a population. So Tirunelveli is also quite a large district. So in that district, we have so many smaller sub-districts. So we can see how much effect and population we have. So because we have quite a lot of rural patients coming to us. So we wanted, as I said, there has been a lot of increase in the number of patients coming to us with cryptogenic cirrhosis. And so we need to know what was the cause, because even on investigation, we couldn't quite come up with the cause. So before that, we needed to know the incidence or prevalence of MAFLD. So that was the need for the study. So we wanted to detect MAFLD as soon as possible to identify those who may have silent progressive fatty liver disease. So that once we identify, it'll be easier for us for a comprehensive clinical management. And we all know, since it is a relatively new term, so there are only few studies which has introduced the routine assessment of fibrosis. So we needed, there's a need to construct a simple, non-invasive and efficient screening tool so that we'll be able to accurately screen MAFLD. And more importantly, the screening tool should be available in all even the peripheral centers where we don't have much of high-end investigations to be done. And it should be easily accessible in all the medical centers so that we can risk stratification and referral to a specialist can be done at an earlier stage before the patient goes in for an advanced fibrosis. So going on to the timeline of the study, so we started off with the brainstorming sessions, and we went ahead with the IRB, or the Institutional Research Board proposal, and we went ahead and submitted the study, start of the study, and most importantly, the data collection and the end of the study. So objectives, okay, so we wanted to estimate the prevalence of MAFLD among patients attending the general outpatient department. And we also wanted to determine the screening indices for predicting individuals at risk for developing MAFLD in a community. So what was the inclusion criteria? So we had adult patients of more than 18 years old. And very importantly, we had to get their consent, informed consent. And they needed to have a radiological imaging features of fatty liver disease. So exclusion criteria, so we excluded pregnancy and patients who already had chronic liver disease or cirrhosis. So a diagnosis of MAFLD was made when imaging showed presence of hepatic steatosis along with any of the following. So when the patient also had overweight or obesity, diabetes, and metabolic dysfunction. So we all know the conditions for metabolic dysfunction. So when the waist circumference is more than 90 centimeter in males and more than 18 centimeter in females, and hypertension more than 130/85 mm of mercury, hyperlipidemia when triglyceride is more than 150 mg per deciliter or under lipid lowering treatment. And when the HDL-C was less than 40 mg per deciliter in men and more than 50 in women, and pre-diabetes of more than 100 mg per deciliter. And we all know the other criteria of HOMA-IR and the HSCRP. So the study period was from February 2023 to September 2023, and sampling method was census sampling. So we included about 2,300 patients sample size, and using the Cochrane formula with a confidence level of 90%, margin of error 5%, and prevalence of 30%. So we followed the hub and spoke model. That is, as I said, so we are based in Tirunelveli. So we have a lot of patients from the different taluks. So that is the Ambasamudaram, Radhapuram, Shankarankoil, Shivagiri, Alangulam, and Naganeri. So these are the different peripheral hospitals. So finally, they will be referred to us. So the analysis plan was the institutional ethical committee clearance was obtained. Consent was got from all patients. Study participants were selected based on the inclusion and exclusion criteria. And socio-demographic data of the participants we got along with the clinical history, examination, and other relevant findings. So this was all noted in a pro forma. And blood samples were also collected. So going on to the data collection and assessment. So the predictor variables were chosen on the basis of the clinical importance and evidence related to MAFLD. And as I said, the demographic details of the patient, that is the age and sex, were documented. Lifestyle habits such as smoking, alcohol, and comorbid conditions like diabetes and hypertension are also obtained. And we also got the anthropometric details such as height, weight, waist circumference, BMI, and hip circumference, which were measured and documented. So the variables, these are the common variables. We wanted to choose variables which could be done at any peripheral center. And based on the previous studies, the variables which we chosen were age, sex, BMI, waist circumference, hip circumference, waist to hip ratio, systolic blood pressure, fasting plasma glucose, the LFT such as your ALT, AST, alkaline phosphatase, your triglyceride levels, total cholesterol, and serum uric acid. And yes, so USG abdomen was done for all patients, and patients with fatty liver were identified, and fatty liver was graded as 1, 2, and 3, depending on the ultrasound parameters. So statistical tool which we used were the mean and the standard deviation was calculated for the continuous variables, and percentage was calculated for the categorical variables. Odds ratio and relative risk was calculated for risk factors of fatty liver, and the chi-square test was done to find the association of risk factors with MAFLD. And t-test was also done to find the difference in all parameters between MAFLD and non-MAFLD. So SPS SS version 2022 was used, and p-value of more than 0.05 was considered significant. So coming on to the age distribution, so the mean age was around 43 years with a standard deviation of 13. And age range, so we had an age range, so we can see it as a wide age range. So from 19 to 78 years. But the majority was seen in the 4th to 5th decade. So majority of the patients were there in the 41 to 50 years, that is around 27.95%. And gender, more of males were included in the study than the females. And the ultrasound findings, no fatty liver was seen in 72%, and grade 1 fatty liver was seen in 20%, and grade 2 fatty liver was seen in 7.86%. So coming on to the important parameters, so we can see that smoking, yes, so around 30% of them had a smoking history. And alcohol was also quite on the higher side, around 33% of them. And diabetes also around 28 to 30%. Hypertension was comparatively little less on the higher, little less on the lesser side, sorry, 23%. And among the total population, among that 27.95 of them had MAFLD. So we can see that The odds ratio was very high with diabetes, hypertension, even though smoking and alcohol is also a risk factor. Here, the relative risk is comparatively less compared to diabetes and hypertension. So diabetes had a relative risk of around 3.96 and hypertension around 2.36, and age was also a very high relative risk factor with an odds ratio of 6. And so the risk of getting MAFLD is more in those who smoke, who consume alcohol, patient who has diabetes, hypertension, and those with age more than 40 and in females. And so on applying chi-square test, we could see there was a significant association for getting MAFLD was found in diabetes, hypertension, and those with age more than 40. And on applying the t-test, independent t-test, we could see there was a significant p-value. So we can see here all the parameters have a p-value of less than 0.05. So we could see here age is important. So BMI, waist-hip ratio, the blood pressure, and the fasting blood glucose. So everything had a p-value of less than 0.05. That means everything has been significant in this study. And along with triglycerides, HDL, LDL, and ALT. So everything had a p-value of less than 0.05, but except uric acid. So that means everything had a positive correlation with MAFLD. So on applying independent t-test, there was a significant difference between MAFLD and non-MAFLD in all parameters except uric acid. So this result is, I just want to so the mean age was 43 with a standard deviation of 13, which I already mentioned. So males were more common in our study population. And more importantly, we could see almost 30% of the study population had MAFLD. And alcohol consumption was also very commonly seen. And as I already said, those who smoke alcohol, diabetes, hypertension, and age more than 40 and females had a higher risk. So conclusion, so our study showed a prevalence of around 28%, which is quite high of MAFLD among the general population. And the actual significant predictors for MAFLD from the study were age, BMI, waist to hip ratio, SPP, that is the blood pressure, systolic blood pressure, fasting plasma glucose, triglycerides, LDL, and ALT. And identifying high-risk groups is key to establishing effective screening strategies. And imaging and serum lab tests can be tailored to detect the disease based on the specific metabolic alterations which are most prevalent in this particular population. So further studies recommended on the usage of non-invasive methods of diagnosis of liver disease and liver function tests so that we can know the follow-up of the lifestyle determinants. So with this study, why mainly we wanted to do studies so that we could have a framework so that if a patient comes to us in any peripheral center, so on screening, whether they need further treatment, whether they need further follow. So once a patient comes to us, so framework for MAFLD at a community level. So phase 1. So whenever an adult attends a medical checkup at a primary care center, so first we need to get a detailed history and see whether the particular individual is at an individual risk for MAFLD. That is family background, high risk ethnic or genetic background. Then they'll be taken up for the phase 2. That is the MAFLD screening. So there we'll do the imaging and all these blood tests. And then finally, if the patient is found to have MAFLD, then we are going to go to the phase 3, where they'll be identified with the specific MAFLD phenotype and comorbidity, and they can be referred to a specialist and with further treatment strategies for MAFLD and the comorbidities. So the limitations, so we need a long-term follow-up to analyze the association between MAFLD and mortality. And liver outcomes, especially advanced cirrhosis and HCC, are still needed to know the natural history of fatty liver disease. So hopefully the impact of this study is so that we could have future references for our MAFLD and setting a baseline for further studies, and it can help us tackling metabolic problems, and so that we can design and implement local care pathways, improve access to effective treatments, and identify interventions with sustained effect. So the lessons which we learned were, it's a simple study, but it could serve as a model for future studies. Understanding our limitations and utilizing our strength, and brainstorming helps, and setting up of guidelines, maintaining hard copies and soft copies, which is very, very important in any study, and knowing our data, troubleshooting, and keeping an achievable target in mind. So acknowledgement. So I would like to acknowledge my HOD sir, and my associate professor who's come with me all the way from India to Japan to hear me present out, and my colleague also. And this is my department, and I would also like to acknowledge the patients especially and the staff and everyone who has been instrumental in the study. So thanks to everyone. So initially we thought the study was very difficult, but as they say, setting goals is the first step in turning the invisible into the visible. So thank you, everybody.
Thank you, nice presentation and good conduction of the study. So the distributors, okay. Short question, please.
So very well presented, and
Thank you.
I am Professor Amanullah Abbasi from Pakistan. So there is a question. You said that the cause of cryptogenic cirrhosis is MAFLD. How you
Okay.
prove that? Number
Cause-
one question. Number two,
Okay.
if the cause is MAFLD, then how we can exclude from the study cirrhosis due to the cryptogenic from this study? These are two questions.
I'm saying one of the causes could be MAFLD because we're having a lot of
Could be, yes.
cryptogenic
Could
cirrhosis.
be. How we can say could be? Do you have some proof for that?
No, sir, because whenever a patient comes, we are definitely going to go about investigating the causes for liver cirrhosis. But we have a lot of female patients and we are not able to identify, they come to us in a decompensated stage, in the final stage. So when we do workup for them, we are unable to arrive at any conclusion. So we are saying it could be a cause for MAFLD. So that's why we are saying initially itself, if we could identify whether they have MAFLD or not, we could go about telling them at least the effective treatment strategies. So we are saying it could be a causative factor, but we are not saying it is the causative factor.
If this could be a cause,
Yes, sir.
there should be an impact of this one on this study.
Sorry, sir.
For example, if
Okay.
20% is the cause
Okay.
of
sir.
this cryptogenic cirrhosis due to MAFLD,
Yes. sir.
but there will be the change in our study if we are excluding this
Yes,
cryptogenic
sir. That's why
cirrhosis.
I've said that we need a
So
long-term
therefore,
follow-up.
I was asking this.
That's
question.
why I said limitation.
This is also a limitation.
Yes,
of the
sir. That's
study.
why I said I have put up
Thank
this
you.
limitation
Thank you.
because we need a long-term follow-up. Yes.
Question?
Thank you.
Okay, we have 1 minute left. I just have a quick question. You started out asking the audience who exercises daily. I just wonder what were you thinking?
No, ma'am, because our audience are all like well-versed in hepatology. And so I need to know whether the awareness among us, because here itself, when we are so much aware, we are not working out and we are not following a healthy lifestyle. So when our rural patients, they wouldn't be aware of all this, so that when a patient comes to a metabolic dysfunction or MAFLD, so that once we find them out to have a metabolic dysfunction, we can go about educating them how to do it.
Thank you.
So last question. So in India, so is it any difference the prevalence of the MAFLD between the city side or countryside? So in the
Yes, sir.
data.
This is both urban and rural. So it's more of a rural side.
And the second question is that you focus on the outpatient.
Okay, sir.
So is it is it a frequency of the MASLD patient is the higher in the outpatient other than the general population or lower?
More on the general population.
General population
Yes.
lower.
Yes.
Thank you. So thank you.
Great presentation. If I can just make one
Yes.
advice is when you present 29.78%,
Okay,
you're
round.
confident that 29.77 or 29.79 is the wrong number, right? So it distracts the audience from the message. You want to say 28%.
Yeah.
That's even too much,
Yes.
right? So I just want to give it a tip
Okay, yes.
because you want to get the message out, not be
Yes.
distracting.
Yeah. Thank you. sir.
As per my knowledge, NAFLD is a lifestyle disorder
Yes, ma'am,
and
definitely.
sedentary lifestyle mostly. So it should be not in a western rural area. It should be in a western.
No, that's what I'm trying to say from the study. It has been increasing in the urban and rural areas. That's the
In-
point of my study.
It was in your study.
Yes.
But in general, when we talk about the prevalence of NAFLD, it varies. It's rural or western? I guess it's western.
We have many studies on Western, right? So this is my study. That's what I want to
Your
present.
study, it's in rural areas.
Yeah, more of a
Uh,
rural area.
Could you please tell me it's what about the ratio of male, female?
We don't have the exact
Okay.
census as such, but
More in a male or more in a female?
in our study, we had more of males.
Males.
Yes.
Okay. Thank you, ma'am.
Yeah, thank
It
you.
was a nice presentation.
Thank
Okay.
you.
Well, I think we just got to the end of the session. Thank you very much for your presentation and thanks for the active participation of the audience. So thank you.
Thanks.
Mhm. Yes, no, just talk. You think?
Last one, yeah,
First one was
yeah,
the
yeah,
best.
yeah. Good,
Okay.
thanks.
Are you going to do
Yeah,
your scores?
Oh, I scored over there.
Oh. Okay.
We
so
have to
then we know
score
that.
now.
Well, so we will,
The name is the first.
this Hu Zhang, right? Shang-Chi.
Just a moment,
Is
please.
that the one?
Yes.
Yeah.
The first is the best. I can. The second is the
Then the
Japanese. Yes.
That he was good too, but no,
Yeah,
not as.
but yeah.
Okay, thanks.
Thanks so much.
Thanks. And I'm moving out. Yeah. Okay, they said that it's gigs. So are we moving out or? Yes, that's mine. Thank you. Yeah, I'm sorry that just, Ray Kim said that I'm staying, so I didn't know that you wanted me to go out. Just a second. Yeah, that was mine. Thanks. Okay, thank you.
Did you just order session or? Last one. On the new session. On the my session. On the new session. 全部って言われたんですよ。そう。これできる。そしたらお願いします。
2番目の
もしもし。
の
Hello, hello.
変更がありまして、
は
同じ種班の先生、同じくパキスタン出身
ああ、
の
そうなん
先生
ですか。わ
が、
かりました。
スライド変更してるんだけど、間に合うかな
Kalpana Acharya.
同じ演題なんですか？
あ、演題は
全く別になるってことですか？
演題は
Eating tube.
同じ。あははあ、わかりました。はい。
どうかしないといけないのか。これを見ないといけないんだ。
みたいですね。あ、わかりました。10分10分でしたっけ？で、10分
全部で1時間。
発表10分、水曜と10分。
20分
あ、それなんか先生、
あ、そうなんですか。トータル20分で何でもいいわけですか。
形
あ、わかりました。
3人合わせて20分ですか？
いいです。
あ
あ、60分です。
あ、60分。あ、結構長い。結構長い。すごいすごい。これは水。これは何？自動的になっちゃう。ああ、どうもありがとうございます。先生、今は内科ですか？
内科ですね。
内科ですね。
Thank you for joining this session. I'm Hayato Nakagawa from Mi University. I will moderate this session with Dr. Jazak. So we have 20 minutes for each presentation. So I appreciate active discussion for the presentation from audience. So first speaker is Dr. Kalpana Akara from India. Please start.
A very good afternoon, respected all present here. Thank you for giving this opportunity. And I'll be presenting a trial, a randomized control trial comparing safety and efficacy of saroglitazar 4 milligram versus obeticholic acid 10 milligram in patients of MAFLD and MASH. And the clinical trial registry number is CTRI 2023 03050 I don't have any conflict of interest to disclose. So since we know that MASH is a burgeoning cause for cirrhosis worldwide, but the actual pharmacotherapy for the same still remains elusive. So far, so if you talk of India, only saroglitazar has received acceptance from drug controller government of India. So the rationale behind conducting the study was to explore the potential efficacy of obeticholic acid in patients of MAFLD MASH and consequently comparing it with saroglitazar. So this was a single center randomized trial. A total of 100 patients were selected for the study, and the patients were randomized into 2 treatment arms. In arm 1, we had 50 patients. So in arm 1, patients received 4 milligram of saroglitazar once daily, coupled with 30 minutes of moderate physical activities 5 days a week. And in arm 2, which again had 50 patients, these subset of patients received obeticholic acid 10 milligram once daily, coupled with moderate physical activity 30 minutes 5 days a week. So this is a flow diagram, a very simple study. In interventional arm A, we had 50 patients, interventional arm B, only 50 patients. And in saroglitazar limb, which is arm A, we lost 3 patients to follow up. So we only have data at the end of 24 weeks for 47 patients. While in obeticholic acid, we lost 5 patients to follow up. So we only have data of 45 patients at the 24 weeks of therapy. So the inclusion criteria of these patients included adults of 18 to 60 years of age who were being managed as NAFLD, or we can say MAFLD. The patients were meeting the definition of NAFLD as per American Association for Study of Liver Disease. There was hepatic steatosis by imaging or histology, no significant alcohol consumption, no competing etiologies of hepatic steatosis, and there were no other competing causes of chronic liver disease. And patients, they gave consent and they demonstrated understanding of the study requirements, treatment procedure, and willingness to comply with all the protocol required evaluation. The subjects underwent fibroscan per the protocol described prior to the enrollment and subsequently, which was at the 24 weeks of therapy. To summarize, the patients who has LSM score of more than 7 kilopascal, increased steatosis as measured with CAP score, or biochemical evidence of liver injury, which is in the form of serum AST and ALT. And the study subjects were also eligible for treatment if either arm, if they had transaminitis, even if when the LSM was less than 7 kilopascal. The exclusion criteria were if patient had significant or excessive use of ethanol for 2 years prior to the initial screening, excessive alcohol intake was defined as 20 grams of males or 10 grams of females of alcohol per day, or if there was alternative cause of fatty livers, including total parenteral nutrition, starvation, or voluntary protein calorie malnutrition, or any drugs which can cause steatosis like amiodarone, tamoxifen, or methotrexate, or anabolic steroids. History of concomitant viral hepatitis or previously being treated for viral hepatitis B or C or autoimmune hepatitis or cholestatic and metabolic liver disease, including hemochromatosis, were excluded. Patients of decompensated cirrhosis were also excluded, and patients who had history of myopathies were also excluded from the study. And pregnant and lactating females were also excluded from the study. So the primary endpoint of our study was change in liver fat content, which was reflected by CAP score on FibroScan, which was measured at baseline and 24 weeks. change in hepatic fibrosis, which is reflected by LSM parameter through fibroscan at baseline and 24 weeks. We also had certain secondary endpoints. Secondary endpoints included change in liver enzymes like ALT and AST, change in lipid profile, serum triglyceride, HDL, LDL from baseline, change in HbA1c, and change in non-invasive scoring methods like NAFLD fibrosis score, FIB-4 and BARD score at the baseline and 24 weeks of therapy. So this is a very busy slide, but since I have highlighted the baseline characteristic between the two groups, that in saroglitazar in obeticholic acid, so the bar diagrams in the yellow represents AST and ALT. Since in saroglitazar lim and obeticholic acid, we can see the mean difference was 18.25 and the ALT mean difference was 2.15, but the p-value was 0.07, which is more than 0.05. So we can say the baseline characteristics of liver enzymes were matched. Similarly, the data in green and blue, that is LSM and CAP parameter, we can see that the mean difference of LSM was 2.91 between the two groups, and the mean difference of CAP was 14.08. And again, the p-value is more than 0.05. So we can say the data were comparable, and patients were adequately randomized into treatment arms. So to talk of saroglitazar lim, we can see that at the initiation of therapy, which is in yellow, the mean AST was 87.91, which reduced to 42.62, and in ALT, it was 106 units, which reduced to 47.74 international unit. And the p-value of these two liver enzymes is 0.01, which is statistically significant. Similarly, in the saroglitazar lim, if we talk of liver stiffness measurement, that is LSM parameter, at the initiation of therapy, it was 14.7, and at 24 weeks, it was 9.61. And this reduction of 5.14 units is statistically significant, p-value 0.01. Similarly, CAP score at initiation of therapy was 307, and at 24 weeks, it was 268. The mean reduction of 39 units is again statistically significant. Now, talking of obeticholic acid lim, if we talk of the liver enzyme, that is AST and ALT, which is represented in yellow bar, at the initiation of therapy, the baseline mean ALT was 83.4 units, and at 24 weeks of therapy, it reduced to 33 units. And this reduction of almost 50 units is again statistically significant. That is a p-value of 0.01. Similarly, talking of liver stiffness measurement, at initiation of therapy, it was 11.84. And at 24 weeks of therapy, it was 8.31. So this mean reduction of 3.54 units of LSM is, again, it's a significant result. And CAP score also decreased from 321 decibel to 251 dB per minute. And this decline of 69 unit was again significant. So now when comparing these two arms, we can see the change in AST and change in ALT in saroglitazar lim is 42.62 mean, and in obeticholic acid is 5.76. Again, the mean difference is 6.86, but if we compare between these two groups, the p-value is only 0.57. Similarly, in ALT, in saroglitazar lim, it is 58. In obeticholic acid, it is 50, and this mean difference is 8.43. But again, if we calculate the p-value, it was 0.56, which means there was no difference between these two groups if we are talking of liver enzymes, connoting a fact that both these drugs had comparable efficacy in reducing the liver enzymes. Secondary, our primary endpoint was liver stiffness measurement. In saroglitazar lim, it was there was reduction of 5.14 units. Obeticholic acid, it was 3.54 unit. This mean difference of 1.6 unit is not significant. Its p-value is more than 0.05. So the saroglitazar and obeticholic acid has a comparable efficacy in reducing the liver stiffness measurement. But if we talk of CAP value, CAP parameter, that is steatosis, saroglitazar reduced it to 39.13 dB per meter, where obeticholic acid reduced it to 69 dB per meter. But this reduction of CAP parameter in obeticholic acid was significantly more than saroglitazar lim. So this is a box plot diagram. We can see this is a pictorial representation in saroglitazar limb, the baseline LSM reduced, and in obeticholic acid again the baseline LSM reduced. Talking of cap parameter in saro limb, post 24 weeks of therapy, there is a reduction. In obeticholic acid limb, it is again there is a reduction from 300 to 280. So this is a bar diagram. In obeticholic acid group, LSM reduced by 20.90 from 11.84, it reduced to 8.31, that is by 20.9%, while in saroglitazar limb, it reduced to 23%, and this p-value of between both the groups were not significant, it is only 0.26, whereas the cap parameter in obeticholic acid reduced by 21.20%, and in saroglitazar limb, it reduced by 10.70%, but p-value was 0.01. So obeticholic acid has added advantage over saroglitazar in reducing the steatosis. So this is secondary endpoint. We can see the AST at the baseline, which is again reduced. Then again ALT is baseline, which is reduced by 24 weeks in both the groups. So this is a pictorial, pictorial representation of change in secondary endpoint of the lipid parameters. This is cholesterol at baseline, which has changed. This is again, there is triglyceride at baseline, which is reduced between the two groups. So AST reduced by 41% in obeticholic acid, by 33% in saro limb. In ALT, it reduced by 46%, whereas in saroglitazar limb, it reduced by 44.50. And while talking of lipid parameters, there's a reverse increase in, it's shown in negative. That means there's a rise in HDL parameter by 7.80% in obeticholic acid, and in saroglitazar limb, HDL improved by 6.50%. So no adverse effect were noted in obeticholic acid, while one patient in saroglitazar limb reported myalgia. So to conclude, obeticholic acid has a comparable effect with saroglitazar in reducing the fibrosis, ALT, AST, triglyceride, while it has an edge over saroglitazar in reducing the steatosis, that is cap parameter. And as reported in previous literature, there was no evidence of dyslipidemia or increased gallstone formation with obeticholic acid. As we, in our study, although the sample size was only 50, we did not find any adverse events as reported in previous literature. So what is the unique about the study? Since saroglitazar has received acceptance from DCGI, obeticholic acid has been barred as of now for treatment in view of unacceptable side effects. So this is one such kind of study comparing these two drugs in MAFLD, MASH. And to the best of my literature, saroglitazar, although it has been compared to vitamin E in Simon's trial, but it has not been compared to obeticholic acid. And the results of obeticholic acid has been contrary to the previous literature. And obeticholic acid has comparable results with saroglitazar in terms of liver enzymes and ALT, but not with respect to cap parameter or steatosis. Although it was a planned or the prospective, this is a controlled study, randomized study, but in our study, we did not perform liver biopsy because liver biopsy is the gold standard when we talk of, when we need to assess the inflammation or the steatosis. It was a single center study. There were less number of patients, so results could naturally be not generalized to the community or to a global level. And in our study, 15% of patients, they had diabetes or pre-diabetes. So they were on drugs like metformin, which could have been a potential confounders, although they were not on insulin and pioglitazone. And it was a hospital-based study, which was a controlled environment. The study could not be, the results could not be extrapolated to the community-based environment. And follow-up duration was only 24 weeks. What if they might rebound? They might come back later with fibrosis after stopping the therapy or the lifestyle modification, which was advised to them. Thank you.
Thank you for nice presentation. Are there any comments or questions from audience? Yeah, yes, please.
Thank you for that presentation. It was good. I'm a bit curious. Was the physical activity in both groups equivalent.
Yes, moderate physical activity included that patients were advised to do cardio exercises of 30 minutes, like running, or if they could join a gym. So, or if they could do 45 minutes of brisk walking, which was explained to them.
Yeah, I appreciate that, but I noticed, I think that was not included in your results on the differences between the activity levels between the two groups.
So when the patients, when they were enrolled in the study, they were explained about the that this is just not the drug. They have to do certain amount of physical activities. So this was like 45 minutes of brisk walking or 30 minutes of jogging or a cardio in a gym, which was explained to them. So when we cannot be isolating the results only based on physical activity, since both these two groups of drug like saroglitazar has already been compared to placebo or lifestyle modification, and obeticholic acid in regenerate and flint trial, they have already been compared to placebo in the form of lifestyle modification. So this time we did not create a placebo limb, and we had merged that physical activity was both these two groups of drug, they were coupled with physical activity. So we did not derive the result in isolation of physical activity.
Thank you for the great presentation. Can you just remind me what was the power calculation behind choosing 50 patients per group?
Basically, 50 patients in each group was with 90% with 90% confidence interval, as guided by our statistician. He said 100 is fair amount with 90% confidence interval. So we took 50 patients in each group.
Thank you.
In your study, you are prescribing 2 drugs.
Yes.
Okay. Do you have any comments on adverse drugs reaction associated with both the drugs? Or how you differentiate whether this effect is related with the disease symptoms or this is related with the drug?
See, we did keep a note on lipid parameters,
Okay.
and we kept our patients on monthly basis follow up, and we have given them their numbers. They did not report, and from biochemically by analyzing the biochemical parameters as well, there was, since from the literature we can see that obeticholic acid causes dyslipidemia, decrease in HDL, rise in LDL, and cardiac increase cardiac risk factors. But when we at 3 monthly interval, when we did repeat the lipid parameters, there was no adverse, there was no deranged lipid profile. Second thing, when we used to repeat the ultrasound, the patients had no gallstones, so we did not find any adverse effect. Although one patient in saroglitazar limb reported myalgia, which could have been because of MAFLD or MASH per se cannot lead to myalgia. So we attributed that this saroglitazar could have caused
Ma'am, how
myalgia.
many ADRs were after your study you
Only one
reported?
patient had myalgia.
Only
That
one
was-
patient.
And that too subsided in a week time. So
And what are the clinical symptoms they had? Actually, for the saroglitazar, when you are prescribing, they have some burning sensation
they
or
have some burning sensation, but our patient only had myalgia.
Okay, so and does any patient is not reported that I have burning sensation? Because the patient who is suffering from NAFLD, they have lots of vitamins and other that important micronutrients deficiency that also leads to burning sensation. So my point is, how do you differentiate between the whether this is a symptom of disease or whether this is associated with your trial?
Since none of our patients
Whether
reported
you
any
perform
burning sensation.
any pharmacovigilance or any causality assessment or any clinical like Indian pharmacopoeia, there is a guideline.
There is a guideline for reporting adverse drug
Yeah.
event, and in that guideline they mention that there is a minor side effects and adverse reaction which led to stoppage of the drugs. So none of our patients had adverse drug
In
reaction
your
which
whole
led to
trial,
stoppage.
there is no adverse drug reaction.
No, only one patient had
Only
mild.
one patient.
Yes.
Okay, thank you.
Yeah, I have several questions, but it's time to move to the next speaker. Thank you.
Okay, thank you.
Okay, next speaker is, I had changed to the new speakers. No? Yeah, please start.
変わりました。
Good afternoon. Thank you for inviting me in this beautiful city of Kyoto, Japan. I'm presenting on the behalf of Dr. Masood Khoso. Unfortunately, he's unable to come here due to some family problems. So our study is about gender-related association of BMI and age with metabolic associated fatty liver disease, cirrhotic liver disease in Pakistani population. It was a cross-sectional study. So I have nothing to disclose. So since morning, we are discussing about this MASLD and SLD, and we all know about the definitions, but the quick repetition, non-alcoholic fatty liver disease will now be a metabolic dysfunction associated steatotic liver disease. And MASLD encompasses patients who have hepatic steatosis and have at least 1 or 5 cardiometabolic risk factors. And metabolic dysfunction associated steatohepatitis MASH is the replacement term for the NASH. So in Pakistan, we are facing a lot of issues with diabetes mellitus and obesity. And meanwhile, like fatty liver disease also increasing in Pakistan. Pakistan is the highest diabetes rate in the world, while a staggering rate of 30.8%, and it is third to India. First is China, second is India, and third is Pakistan on rising number of diabetes mellitus. And this can be attributed to several factors, including lack of awareness and education about diabetes. People are using remedies for the management of diabetes, high prevalence of obesity in Pakistani population, rapid urbanization, and poor access to healthcare facilities. A diet high in carbohydrate and sugar, along with sedentary lifestyle, are common among the population, leading to an increase in insulin resistance and diabetes in our population. So objective, the study was conducted to determine the association of MASLD with age, gender, and body mass index. The study was conducted between January 2020 to September 2023 in the Department of Gastroenterology and Hepatology, Jinnah Postgraduate Medical Center, Karachi, Pakistan. And Jinnah Postgraduate Medical Center is the largest tertiary referral center of Karachi, Pakistan. And Karachi is the metropolitan city. Inclusion criteria, both male and female patients of age more than or equals to 18 years with ultrasound finding consistent with MASLD or fatty liver were included in the study. We exclude autoimmune liver disease, liver cirrhosis, viral hepatitis, hepatocellular carcinoma, alcoholic liver disease, and pregnancy. So the study was started after the approval from Institutional Review Board, Ethical Review Board. And patient consent was also sought after explaining the purpose and future benefits of the study in detail. So in the patient and methods, we have recorded the demographic features in a preform performa, and we have included the gender, age, residence, social status, and marital status of the patient. Anthropometric measurements were made like weight, height, BMI, waist to hip ratio. And in the laboratory and ultrasound findings, we have recorded the findings of lipid profile, liver function test, blood sugars, imaging examination like ultrasonographic findings. For the waist to hip ratio, just for the understanding of the people, we use this waist to hip ratio in women is 0.85 plus is high, which is apple shape, or 0.81 to 0.85 is moderate, or 0.80 or below is low. And in men is 0.95 or below is low, 0.9 to 1 is moderate, and 1 plus is high. And we have used the Asian BMI classification. Data analysis was conducted using SPSS version 22. For continuous data, mean and with standard deviation was computed, and for categorical variables, frequencies and percentages were computed. The independent sample t-test was used to compare the continuous variable groups of 2. So in the results, most commonly in our study, as earlier presented by the Divya, in their study, their male predominance. But in our study, we have included 827 patients, in which 650, 78.6% of the patients were female, and only 177, 21.4% of the patients were male. Baseline and clinical characteristic of study participants. Initially, we have enrolled 1140 patient of MASLD, out of which 827 were analyzed and rest of them were excluded. So we have compared these cases with the controls. So mean age in male and female is almost, there is no such big difference, 42 with standard deviation, 40.8 with standard deviation of 10.8 in males and 42.5 with standard deviation of 10.1 in females. 43.5% of the patients were hypertensive and 19.9% of the patients were diabetic in our group. Waist to hip ratio is 1.07 with standard deviation of 0.06 in the cases. And mean BMI was 29.49 with standard deviation of 5.8. Triglyceride levels was high in the cases. And mean ALT was 33.1 with standard deviation of 36.2. And most of the patients, the cases have deranged fasting blood sugar levels with significant p-values. So in our MAFLD cases, only 1.7% of the patients were underweight, like lean MASLD cases. Healthy weight is only present in 17.8% of the patient, overweight 35.1%, and obese 45.3%. So in our study, most of the patients were overweight and obese. Age category with gender-wise distribution. So you can appreciate in these slides, in 18 to 34 age bracket, only 57 patients were male, 121 were female. And in this age group, most patients will lie in this age group between 35 to 49, which is the most productive part of the life. 84 were male and 341 were female. And very few patients encountered in this age group, which is more than 65 years. So steatotic liver disease in our patient, total 827 patient, MASLD was encountered in 633, 76.5% of the patient, and MASH in 194, 2.4% of the patients. So in this study, we did not get any significant association of MASLD with age. There was highest frequency of MASLD among females, 78.6% as compared to males. And among middle age group, which is 35 to 49 years as compared to the young and the old age group patients. Significant association was observed with overweight patients with BMI of 29.49 with standard deviation of 5.8 as compared to control in obese patients. So in conclusion, in this study, age between 35 to 49 years, female sex, waist to hip ratio of more than 1.07, mean BMI of 29.49, and glucose intolerance were the predictive factors for MAFLD in the study. Thank you.
Thank you. Are there any comments or questions from audience?
Is there any reason that less number of male patients have been included in the disease and more of a female in this?
We have included all the patients who presented in outpatient department with symptoms and ultrasound findings of fatty liver or fatty liver. So most of these patients, it's a cross-sectional study, single center. So we have enrolled all the patients with ultrasonographic finding of fatty liver. Most of these patients were female.
And subsequently, since the patient, you have collected the patients only from a tertiary care center.
Yeah.
I think will it reflect the general population?
We are working on this study. We are recently working on this study. So we want to include other areas as well. So it's an ongoing study. But currently this data is from our center, and our center is the largest referral center. So most of the patients are referred from primary or secondary healthcare to our hospital for the management.
And is there any attempt to investigate this patient for the diagnosis of fibrosis or steatosis with FibroScan?
No, we haven't done.
Is there any
We just performed the ultrasonography in these patients.
Is there any reason for that?
No, not such. There is no such reason. We just included this patient. But in the future, yes, we want to include the fibroscan in this patient also.
Is it available in your center?
Yes, it's available, but most of the time the machine is out of order. That's why we are not included all the patients. We have done fibroscan in few patients, but not all patients. That's why we are not added. But in the future, yes, we are planning another study with fibroscan.
Fibroscan in the sense is a EcoSense from France.
Yeah.
Yes, we do have a fibroscan in our center. Almost we are doing, and we are taking the fibroscan to the community. We are taking to the rural areas.
Okay,
so
good
that
step.
the exact reflection of the this is an ongoing study in our center that took the fibroscan, which is almost 1.6 crores in cost, and we are doing the study, and we will be publishing soon. Thank you very much.
Good suggestion. Thank you.
Thank you.
In your study, more female and less male. Okay. For the Pakistan, India, or some few of other countries are like either they are low income country or middle income country. For the India, most of the males were suffering. So do you please explain what were the reason why females were more and less male?
This is a study finding.
They were what? At least you have some reasons or something. Why this scenario has totally changed for your study? But for the India, more are male, less are female.
Yes, in the Divya study, there are more are male, but in my study, more are female. But this,
Why?
but
Pakistani females are more aware
Pakistani females are more obese as compared to the Indian females. They are
the
more obese.
They were doing more
And
households.
yes, household, and they spend sedentary lifestyle.
Okay.
They married early. They married early, then they stopped working.
Indian women, they are doing work outside their homes.
Yes, they are mostly household.
Pakistani ladies,
Housewives.
they are inside the home and spending the sedentary lifestyle.
Is there any
This is the
publication
difference.
for the prevalence or incidence for the earlier
There are very few
or in
publications
your
from
own
Pakistan.
studies, female or more or male are
There
less?
are very few publications
Studies are
on
there.
MASLD from Pakistan, and we are currently working on that.
Okay.
There are very few published reports.
In India, also female were suffering. It's not a gender biased disease, but due to let it be scenario, more males are coming to the clinics and female will let it be. Then in
Pakistan, it's opposite.
Yeah, well, that's why it's a good thing, not a good thing, but I just want to say, what were the reason?
One thing I'm telling you,
diabetes, what are the scenario of diabetes? Whether more in
diabetes,
female?
yeah, more female are diabetic.
Okay.
As compared to male, more female are diabetic. One thing is mostly females are housebound households and housewives. So coming to the hospital is their enjoyment. I'm telling you, this is in Pakistan. They enjoy in hospital. So they get chance to go out from the house. So that's why I think more female and male usually ignore their problems. That's why I think this is the reason.
Okay, thank you.
But this needs again research.
Thank you.
Thank you.
Any other questions? That's okay. In Japan, MAFLD is more prevalent in male, so I was surprised at your result. And are there any genetic background to explain this difference?
We haven't done any genetic analysis in our patient, and in Pakistan, research is very lacking. There is very lacking in research areas in genetic aspect, and still we are working on epidemiological studies. We are working on the frequencies and other things. So we haven't gone for the this genetic test, but definitely in the future.
Yeah.
Thank you.
Yeah, thank you.
Next, I would like to invite to the podium Mr. Yi-Tin Cheng from Taiwan, I guess. It's National Yanmin Chao Tung University in Taipei City. And she is going to present about the long-term risks for cirrhosis and HCC across steatotic liver disease patients. Please go ahead.
Thanks for Professor's kind introduction, and good afternoon, everyone. I'm Yiting Chen from National Yangming Jiao Tong University in Taiwan. And I would like to thank APASL for giving me this special opportunity to present in Young Investigator Workshop. And today I'm going to share my research titled Long-Term Risks for Cirrhosis and Hepatocellular Carcinoma across Steatotic Liver Disease Subtypes. And we have nothing to declare for this study. Back in the day, we used to think that fatty liver disease is mainly linked with excessive alcohol consumption. But after lots of related research, there's a series of nomenclature transition in fatty liver disease. First, in 1986, some experts found that some of the patients, they may also get fatty liver even without heavy drinking or other known liver disease such as hepatitis viral infection, and they are defined as NAFLD, non-alcoholic fatty liver disease. But however, some other people think that this kind of exclusion criteria may overlook the patients that is excluded by this definition. So in 2020, they came up with a new term called MAFLD, and the MAFLD is metabolic dysfunction associated fatty liver disease. And MAFLD include the metabolic risk factor, and because of the inclusion criteria, the patients with other liver disease will also be included in MAFLD patients. But fast forward, there's another group of experts thinks that this kind of coexistence of the risk factor may cause the misclassification of the causes. So, and also they think that the term fatty is kind of stigmatization. So in 2023, we get our latest steatotic liver disease definition, MASLD, and they changed the term fatty into steatotic. And instead of the binary system, they focus on both cardiometabolic risk factor, also called CMRF, and the alcohol consumption rate. And they divided the patients with steatotic liver disease into mainly three groups: MASLD, MAFLD, and ALD. And other known liver disease are considered separately. And in the MASLD group, they are for the patients that is with CMRF, but limited alcohol consumption. And the MAFLD group is for those with both CMRF and the moderate alcohol consumption. And those with excessive alcohol consumption was straight into the ALD group. And because this nomenclature just announced last June, and it's about 9 months since then, and so as far as I know that there's not yet any large-scale research discussing about the association between the steatotic liver disease subtypes and the advanced liver disease. So my aim is simple, that I want to use the long-term follow-up to investigate that whether this kind of various subtypes of steatotic liver disease can effectively identify the high-risk group of cirrhosis and HCC. In my cohort, first, I exclude the patient that is with prevalent cases of cirrhosis and HCC, and also they'll present the seropositive or HBs antigen and anti-HCV. And also, we exclude the patient that lack of the data required for MASLD definition, and it ended up with a study population of 300,000 people. And the next step, we use the ultrasound information to define the ASLD status. And in the ASLD patients, we will divide them into MASLD, MAFLD, and ALD based on cardiometabolic risk factor and the alcohol consumption rate. And the non-ASLD group will serve as our reference group for the following analysis. And we can see that the MASLD patient stands for the largest subtypes among the ASLD patients, and it's about 80.8%. And in the disease definition, we gather the information by linking it with the nationwide data set. And this data set covered almost 100% of Taiwanese population. And like data set like cancer registration and the death certification, they are all legally proved. So we can ensure our high accuracy of the disease definition. And after the follow-up, we identified thousands of HCC cases and 4,000 of cirrhosis cases. And in the baseline characteristic, we can see that in the ASLD patient, including MASLD, MAFLD, and ALD group, they tend to be older and obese. And nearly half of them have the status of metabolic syndrome. And when we come to the liver-related seromarker, we can see that SLD group present the higher ALT and AST level, and the AFP level were increased with the alcohol consumption rate when compared with the non-SLD group. And next is the incidence rate. When we compare MASLD, MAFLD, and ALD with non-SLD group, we can find that the incidence rate of all three groups is higher in both cirrhosis and HCC, and especially in the ALD group. And the ALD group has the highest risk of both chronic liver disease and followed by MAFLD and the MASLD patients. And when we consider the cumulative risk of cirrhosis and HCC after a median follow-up of 16 years, and the ALD group also, still remains the highest risk for the cirrhosis and HCC, and followed by MAFLD and MASLD in both disease. And moreover, we conduct a multivariate adjustment in the regression model. And in the main result, we use non-SLD as a reference. And when we compare the hazard ratio, and we can see that the group with more alcohol consumption like MAFLD and ALD, they have higher risk to develop cirrhosis and HCC when compared with MASLD. And even in the MASLD group, they have a 30% higher risk to develop chronic liver disease when compared with non-SLD group. And in the sensitivity analysis, we use a non-SLD without any CMRF patient as a reference, and the sensitivity, the trend of the hazard ratio remained the same and even higher than the main results. So in quick summary, first, we use the ultrasound information to define the SLD status, and then we use the cardiometabolic risk factor and the alcohol consumption trait to divide the SLD patient into MASLD, MAFLD, and ALD based on the latest nomenclature of steatotic liver disease. And then after 16 years of long-term follow-up, we found that all three groups present higher risk for cirrhosis and HCC when compared with non-SLD group. And this indicates that the alcohol consumption rate and the metabolic risk factor are two independent predictors for the chronic liver disease. And among them, the MAFLD and ALD group emphasize the risk for cirrhosis and HCC, and which means that this new nomenclature can successfully distinguish the high-risk group for chronic liver disease. And the strength of our research is that first, we use the comprehensive ultrasound information, and then we have a large cohort of population and long-term follow-up. And also we linked the data with national computerized. We linked the national computerized data to define our disease. So these strengths can make us have the enough cases of cirrhosis and HCC, and also we can ensure the high accuracy of our SLD and disease definition. And in the limitation, alcohol consumption and the cardiometabolic risk factor trait are assessed only at baseline, although they may change through the follow-up. And last is the discussion section. We found that there are 36% of patients in non-SLD group, they are without any cardiometabolic risk factor. And we can see in this table that the incidence rate of cirrhosis and HCC in non-SLD without CMRF group, they are all lower, maybe 2/4 or 3/4 lower than the non-SLD group. And this situation indicate that in the non-SLD patient, they can maintain their health by some behavior modification like health, dietary, or the exercises to keep themselves without cardiometabolic risk factor. And this also is an important way to let this group of patients that can decrease the risk for the advanced liver disease. And last, I want to thanks for all the members in our lab, especially my advisor, Professor Mei-Shen Lee. She really support me a lot and give a lot of contribution. And I want to thank all the support and grant from this institution and article and co-author, reviewers, editor from the American Journal of Gastroenterology for their acceptance. And last but not least, I want to thanks again for APASL for giving me this special opportunity to present here. Thanks for listening.
Okay. Thank you, Dr. Yiting Chen. And now this presentation is open for discussion. Please present yourself and introduce yourself.
Thank you. I'm Shangxun Huang from Taipei, Taiwan. And congratulations on eating excellent study. I have two questions, small questions. The first one is in Taiwan, the majority of patients with HCC may be caused by viral hepatitis, which means HBV or HCV. In your study, you exclude patients with chronic HCV infection, but there are still some patients with chronic hepatitis B. So what's the proportion of the adverse liver outcome, including your data cirrhosis HCC had concurrent chronic hepatitis B? Because this is an important factor may induce cirrhosis and HCC. This is my first question. And the second question, in your presentation, you show that you link your patient to the national death certification system. So how about the mortality rate among these patients? Thank you very much.
Okay, thanks for your questions. And can I, yes, thanks for the, okay. And the first question is that because Taiwan is an endemic area for the HBV and HCV infection. And the reason why we exclude the patient with chronic hepatitis B and C is because that in our another analysis, we compare the MASLD and the hepatitis B or C infection together, and then group the patients into 4 groups, which is MASLD with chronic liver disease, and non-SLD with chronic liver disease, and MASLD without chronic liver disease, and non-SLD without chronic liver disease. And in this result, we can see that the chronic liver disease always dominates the risk of HCC and cirrhosis in Taiwan. So to simplify our research, we exclude the chronic liver disease, although we know that this is a really high risk factor for the HCC and cirrhosis. Okay, and the second question is about the mortality of the data linkage. And this time we use the outcome of the HCC and cirrhosis instead of the mortality rate. Yes, but we also can link with the mortality to do some further research. Okay, thank you.
Thank you. Thank you very much.
Yeah, please, next.
I'm Haito from Osaka University. Thank you. Good, nice presentation. And I missed your slide. So you showed that ALD and MAFLD is the risk factor, important risk factor for HCC or liver cirrhosis. My question is so if you analyze the multi-factor, including the Cox hazard model, so these criteria, the independent risk factors of HCC or liver cirrhosis, for example, the independent with ALT levels or liver fibrosis related factors or something else.
Did you mean that did I adjust for other risk factor? Yes, we in the multivariate adjustment, we in the cirrhosis we adjust for age, sex, smoking, and FIT4, and in HCC we adjust for age, sex, smoking, AFP, FIT4, and family history of the liver cancer. Okay,
thank you so much. So both the factors is independent. Okay.
Yes.
Thank you.
Thank you.
My name is Chileka from Hong Kong, Hong Kong Polytechnic University. Thank you so much for this presentation. Looking at the last 2 presentations from India and from Pakistan, I'm now curious to know the prevalence of male, female in the distribution of MASLD, MAFLD, and ALD. I don't know whether you have that data with you.
Oh, and I didn't show it, but our prevalence of sex is, wait for a second. Oh, in our Taiwanese cohort, the female has a higher prevalence in the MASLD group. Yes.
Okay. Can I ask a question? I think you used your national health program to pick up this data, right? No? Or the data you got, like you have a lot of data from the, I think it's National Health
That
that
has everything.
that's why you don't have fibroscan elastography results, right? No?
Yes, because our cohort is using a health screening program, so most of them undergone the ultrasound. Yes.
Ultrasound, okay.
Thank you.
Please,
Now I have
please go
one
ahead.
question. You showed the risk of cirrhosis is highest in ALD, but the risk of HCC was similar between ALD and MAFLD and rather higher in MAFLD, right?
Yes.
So in such case, some kinds of metabolic factors may influence on the HCC risk independent of the fibrosis, right?
Yes.
For example, did you check the prevalence of diabetes mellitus in your cohort?
Sorry, can you repeat?
I want to ask you, so the prevalence of diabetes is different between the three categories?
Diabetes, the
Yes.
rate of the diabetes.
Yes.
Is different. The question you mean is that is the diabetes rate is different from in the MASLD, MAFLD, ALD groups? I didn't do this kind of baseline characteristic, yes, but I think they are different. Yes, okay, thank you.
Okay, thank you very much. So this session is finished. So maybe we could, because we have some time, we could move to the next one. Maybe. 3分ぐらい残ってるけど、いいんじゃない？ね。Okay. お疲れ様です。
from the first present data from the China, I think. Yeah. Let's see that.
So I can start now, right?
Oh, yeah, of course, yeah, you can start from the self-introduction. Sorry that.
Okay, very thanks for this opportunity to share our recent findings on the prevalence and clinical profiles of the primary sclerosing cholangitis in China. Professor Ji Dongjia had received grants from Gilead Sciences, and other authors declare no conflicts of interest. The disease primary sclerosing cholangitis, short for PSC, is a rare progressive disease, and it correlates to the severe outcomes, but there is no effective treatment other than the transplantation. On the epidemiology data, globally, there is only limited national or regional data, and with great geographic variations. In China, this epidemiology of PSC is wholly lacking. The reason is due to the high cost and low feasibility of conducting population-based studies for rare disease like PSC. Besides, there is no national or large-scale registry data for PSC in China, so this actually limits analysis using the electronic medical records. Besides, most PSC articles were published with case reports or small sample size, so this makes it impossible to pull the prevalence through the meta-analysis. But there is a method called multiplayer method has provided a feasible way to combining these two data sources together to estimate the prevalence. Therefore, in our study, we aim to estimate the prevalence of PSC in China, and we aim to depict the clinical profiles of PSC in China. In our study, the PSC cases were identified from two data sources, EMR and SLR. So for EMR data, we have identified PSC cases from 269 hospitals for China, and the cases were identified using the ICD code and keyword search. Only cases diagnosed between the year of 2000 until 2023 were included for our study, and we also conducted the manual chart reviews to ascertain the cases. Then for the SLR, we have searched PubMed and other three commonly used Chinese literature databases for the PSC publication. The studies reporting number of PSC cases, the time period of diagnosis, and hospitals where the cases were identified were included in our study. While for studies reporting numbers less than 10 and reported from the non-tertiary or secondary hospitals were excluded from our study. The key information in our study is to estimate the prevalence of PSC. So two parameters were actually needed. The first is the total number of PSC in China here, and the second is the general population size in China. Then for this second parameter, we can directly retrieve from the consensus yearbook. The key is to estimate the first parameter. So here we used the multiplier method. In this method, actually two indicators were required. One is the benchmark B, and another is the multiplier M. For the benchmark in our study, we estimated using the total number of the cases retrieved from both data sources. And for the multiplier, we approximately estimated using the outpatient volumes from the studied hospitals and the volumes from the hospitals in China. Finally, we have included 1,358 cases from both data sources for the prevalence estimation. By using the multiplier method, we have estimated that the prevalence in China of PSC was 2.36 per 100,000 persons. When we look at the data within Asia, we could find out the prevalence in China was slightly lower than that from Israel, but currently higher than that from Singapore and Japan. And then when we look at the data from globally, we find out the data from Asia countries were generally lower than that from the Oceania, Americas, and Europe. So whether this difference is due to the genetic or environmental exposures is unknown and remains to further studies for determination. We also analyzed the prevalence by gender in China, and it identified that males have slightly higher prevalence than females, and male also accounted for 56% of the total cases. So there, in previous studies, there has been the classical dogma to show the male predilection for PSC cases. This male predilection actually means that more than 65 to 70% of the total cases were identified in male patients. But in our study, this data is 56%, so this might indicate that the male predominance might be less apparent in Chinese PSC patients. Here, we also presented the prevalence by geographic regions, and it shows there were higher prevalence in East China and North China. So this might be due to that the two famous mega cities, Shanghai and Beijing, were located in these two areas. Especially for this East China, it gathered for so many wealthy cities and provinces here. This reason is supported by a study from Spain to show that there would be more PSC cases detected in the industrialized regions. Then similarly with these results, our association analysis for the microeconomic indicators with prevalence have showed the same results. The GDP and healthcare expenditure were the indicators that positively and independently associated with higher PSC prevalence. So this might be due to that in the more developed areas, there would be better expertise in doctors and better accessibility to MRCP. So this MRCP is actually the gold standard to diagnose PSC patients. And also, there might also be referral effect next to the higher prevalence detected in more developed areas. This means that more patients would come to higher level hospitals for better diagnosis and better treatment. Another finding of our study is that the concomitant IBD prevalence in PSC patients was 26%, and we can know from a figure that this data was lower than that from other countries. So we analyzed that this reason might be that not all patients in China have received the endoscopy examination, although it is recommended by the clinical guidelines. Well, for another part, there is a systematic analysis to show that the IBD prevalence per se in China was lower than that from the Western countries. This corresponds to the 47 versus more than 100 per 100,000 persons. We also conducted the comparison on the biochemistries from two data sources. So for the SLR data, we have pulled the mean levels from different studies. And for the EMR data, we calculated directly from the individual data. So the results have showed that the levels between the two databases were similar. This also have supported the robustness of combining these two data sources together. There also have several limitations for our study to acknowledge. The first is that the early stages of the cases might be missed, and this could lead to the underestimation of the prevalence. Second, the expertise of diagnosis may be different among the different geographic regions, so this might compromise the comparison between different regions. And also because we cannot get the onset age for every cases, so the age standardized prevalence cannot be calculated in our study. Although with the previous limitations, our study is still the first prevalence estimate in China from past 2 decades. This was 2.36 per 100,000, and this is generally lower than that in Western countries. And we also find that the prevalence is higher in males, but this predominance is less apparent. And also the prevalence, or to be more accurately, the detected or reported prevalence is higher in more economically developed areas in China. Also from the clinical perspective, the concomitant IBD is lower in Chinese PSC patients. So these results might inform that future basic science research might be needed in Chinese patients. And we also acknowledge the distributions from other co-authors and the research grants and also the technical assistance from other teams. And thank you very much for your attention.
So thank you for a great presentation, and let's start off with discussion about this paper. Do you have any question? No. So I have several questions, but do you think the number of the PSU will increase in China in future? Or not?
Actually, we have analyzed this data by period between 2010 and after 2010. Actually, it's kind of doubled after 2010. So it's possible the prevalence might be increasing. But I think the reason is we can say that the prevalence is increasing because there has been increased accessibilities for the MRCP. So it might mean that the detected prevalence was increasing.
I understand that they are, sometimes, underestimated of the diagnosis due to the technical issues, like, for the, for the MRCP skills or the other, and the knowledge of the PSC. But how about, increasing IBD will affect the number of the PSC or not? Maybe the Asian people has a number of the IBD in Asian people will increase in the future, especially in same as Japan. But
actually, as I understand from papers, it's still not very confirmed that does IBD happens before PSC or PSC before IBD. So I'm not sure whether the IBD increase would lead to the increase of the PSC. We can only say that there were correlations between the two diseases.
I see. Maybe for my understanding, that in Japan, but number of the IBD and the number of the PSC are correlates for increasing. So maybe it's maybe similar to China in future, I think. So that's why I just asked this question.
Yeah.
Do you have any question? Yes, please.
Thank you, Dr. Zhu. It's a wonderful presentation. And to my knowledge, and the prevalence of primary sclerosing cholangitis is rarely estimated in the general population. What's the study population? I wish to know. What is the study population you have selected?
You mean the absolute number of cases in China?
No. In your study, what's the
total numbers?
Numbers and which population?
It's actually included 1,300 cases in our study for these PSA cases to serve as the nominator.
Patient from about all, it is from the directory, reported from various places.
Yeah, we included
from electronic records only it has been selected.
26 provinces in China, and it's collected from the hospital heat systems and also from published the articles.
Okay, so if we compare when we randomly selected, if it is selectively, it has been it's been reported. Actual prevalence rate, when we screen the entire population, I think it will be different. Will it reflect the same thing as that of that is reported as the records? If it is only records purposes, they have been reported, and will it reflect the exact prevalence of sclerosing cholangitis?
I'm sorry, I did not understand what you mean by what difference.
Actual prevalence of the disease of the primary sclerosis cholangitis, I think it will be much more than that of actually reported one in the population. You are only electronically, you were collected only the electronically, all the records, going through the records only, it has been how much cases has been reported. We are not screening, almost the general population is not screened. We are not screened the entire population. It's only the reported cases only it is being taken into. Will it reflect the exact prevalence of sclerosing cholangitis in the general population?
You mean the gender difference?
Yes.
Yes. In our study, the male prevalence actually is higher in females, but the predominance is not apparent than that from Western countries. And actually, I also have seen other papers from the autoimmune liver disease, like for PBC and AIH, the females actually have higher prevalence than females. And there were also evidence to show that the higher female prevalence actually correlates to the later onset age for this disease. And in one study, it had showed the mean age for onset for PBC and AIH is like 60, but for PSC is 40. So this might support that the hormone have different impact in males and females.
Okay, thank you.
Thank you for your question.
Thank you very much. Do you have any other question? No. So thank you very much for the great presentation. Let's move on to the next paper. Thank you very
Thanks
much.
for moderator.
Thank you. So I'd like to invite the next presenter, but we cannot find the other two presentators, so the session may be closed in one presentator, but is it okay? Okay, Dr. Zub, thank you for a great presentation. Thank you very much. Thank you.